but I don't think here in Indonesia we are quite familiar with this kind of procedure. So if we look from the posterior surgery, this is one of the preserving motion and stability surgery for cervical disc disease. It can be done minimally invasively, so it's definite that we can do it using the endoscopy, and we can directly evaluate and mobilize the nerve root. But the risk of bleeding and the risk of nerve injury and facet violation is quite big in doing this kind of surgeries. So this is one of our obstacles in doing the posterior procedure. So if you look at the evidence from the North American Spine Society, they both recommend the ACDF or posterior laminoforaminotomy for cervical radiculopathy. And it is suggested for a single level degenerative cervical radiculopathy for using this kind of procedure. But we have to remember that this kind of procedure is not without a problem. Yeah, according to the research in Sweden, from the Swedish Spine Register, if we do the foraminotomy, there will be more efficient in the long run. Yeah, even though the short-term results comparing with ACDF is quite the same. Yeah. And also Sebastian Rutten, also one of the big guy in endoscopic spine surgeries, also told us that there is limited possibilities to expand the operation. Yeah, if there is some problem, we could not do anything. We could not expand the operation from that kind of condition. Yeah, probably facet violation and also some bleeding that caused by our procedure. So this is the indication. Yeah, definitely it is a radiculopathy, lateral disc herniation, foraminal stenosis, and the contraindication is first myeloradiculopathy, but this is actually relative. Sometimes I also do central decompression for the cervical spine in case of myelopathy, and I never do that with the patient of loss of cervical lordosis. So I always evaluate before the surgeries whether the lordosis of the cervical spine is intact or not. And loss of disc height is also a relative contraindication for this kind of procedures. Usually loss of disc height causes cervical kyphosis, which is one of the contraindication for doing cervical foraminotomy. Central disc herniation, which is quite hard, but I saw some of the surgeons are also doing the foraminotomy from very far lateral to access into the central disc space. Central osteophyte is quite hard to get from the posterior foraminotomy, which is better from the anterior part, and also cervical fracture, tumor, and OPL. So if we want to do a cervical foraminotomy, there are some things that we need to consider. First is the clinical anatomy of the foramen or nerve root. In the cervical spine, the distance between the location of the nerve root is quite inconsistent. Sometimes it is located more to the cranial pedicle, sometimes it's located more to the inferior pedicle. So we have to evaluate that intraoperatively, whether it is located to the upper part or whether it's located to the lower part. And the distance between the pedicle and the nerve root is also variable between between the upper cervical level and the lower cervical level. And the space that available for discectomy is also variable. Sometimes we need to do superior pediculotomy to access the disc, or sometimes the disc is already wide open and we can directly go and take the disc. And sometimes anterior osteophyte and medial disc herniation need special attention to prevent injury to the spinal cord. So this is one of the studies comparing the distance between the thecal sac and the nerve root, and also the availability of the disc space in the axilla level. sometimes we need to get or access the disc space from the shoulder level, or sometimes from the axial level. But in the cervical spine, most of the time I always do the discectomy from the axilla level. So the tools and instruments that we need for foraminotomy, of course, we need normal surgical instrument. We need the lens, we need the Harrison punch, we need the retractor, we need root retractor, and also this retractor. Yeah, and also we need some tools to coagulate and ablate. Yeah, using this Bones instrument is very useful. And for the cervical foraminotomy, one of the things that is very important is the tip type of ablator like this, because it's very useful to control the epidural bleeding. So, and then the other thing is that we have to put the patient in straight neck. Yeah, I always try to lost the cervical lordosis, yeah, to increase the foraminal space and increase the space for discectomy. And like I said before, the epidural bleeding has to be meticulously controlled using the tip control ablator. So this is the steps for doing the biportal foraminotomy. First, we have to make the portal, and on the AP view, our target is the uncus from uncovertebral joint from the AP view. So we have to land on that part of the area. So actually, on the posterior part, it is located on the facet joints. Yeah, but on the AP view, it's maybe around laminofacet junction. So this is how we view it from the lateral part. And then first we have to find the V point, the border between the upper lamina and the lower lamina. Yeah, we have to find the V point first. This is the endoscopic view of the V point. And we need to resect the medial side of the IAP. And then after that, we have to resect the superior part of the ACP, and sometimes we have to do the pediculectomy. And then doing the flaphectomy, and then root mobilization and discectomy. So this is one of the patient that I did. This is a foraminal herniation, left side foraminal disc herniation. We did a biportal endoscopic foraminotomy. Yeah, first we find the V point, we evaluate the facets. So we drill up the IAP, and then drilling up the ACP, and removing parts of the ligamentum flavum, the lamina. And then in this patient, we need to drill up a little bit of the pedicle to access the disc space. Yeah, so this is the tip control that I told you before. It is very useful to control the epidural bleeding. You see, the space available for discectomy in this patient is very narrow. It's almost we almost have no space, because the nerve root is located very close to the inferior pedicle. So the size of the disc herniation in the cervical spine is usually very small compared to the lumbar spine. So sometimes when we didn't do the discectomy, or only do the posterior foraminotomy like this, sometimes it's already helpful to the patient. So this is another patient with 2-level foraminal stenosis. So I managed to do the surgeries with one viewing portal and one working portal, so I can do 2 levels simultaneously. So first of all, we have to clear up all the soft tissues around above the facet joints until we can see 2 facet joints using our endoscope. Yeah. So at this level, you can see 2 facet joints here, and then we do the foraminectomy accordingly, same as before, up until we can see the exiting nerve root clearly. So this is the first level. This is the lower level, and then we move to the upper level, opening up the exiting nerve root, and then after that we can see both of the foraminal area already decompressed. So this is the results after the surgeries. We can see 2 holes within the foraminal area with good preservation of the facet joints. So this is our results of posterior cervical foraminal procedures. I've published my research recently, just this month. So the result is quite all right. I had no complications in, major complication in doing the cervical foraminectomy. All of the patient has a good results. I had no instability of the cervical spine after the foraminectomy in 1 year. I don't know. Probably in the next, in the long run, there will be some instability after the procedure. But within 1 year, there was no instability, and there is no neck pain, obviously, after the surgeries, and the arm pain is already decreased. And during my time doing the full endoscopic foraminectomy, I had 2 patients that had incomplete decompression, which I did during my earlier case. What happened was I didn't resect the medial part of the facet quite a lot. So one of the important thing when doing the posterior foraminectomy, the end goal of decompression is palpating the lateral margin of the pedicle. So we have to palpate the lateral margin of the inferior pedicle to make sure that our decompression is enough. So I had no instability after posterior foraminectomy. I had 3 patients with numbness, but it resolved after time. So in conclusion, the evolution of optics and instruments enable us to perform posterior procedure safely, and the evaluation of nerve root is better in endoscopic posterior approach compared to the anterior, in my opinion. And foraminectomy is one of the options for management of foraminal stenosis with low complication rate, and it is one of the options for cervical radiculopathy with good intervertebral state to prevent this replacement or ACDF. So thank you. Back to you, Dr. Richard.
Thank you, Dr. Asrafi Rizky Gatam. Thank you for your punctuality, and due to time constraint, I'd like to move to another speaker. Our next speaker is Dr. Harmantia. He is our rising star, the young surgeon. Please, the time is yours, Dr. Harmantia.
Thank you, Dr. Syafruddin. Can you hear me?
Yes, I can hear you. I can see your presentation as well.
Okay, so good afternoon from Indonesia for all of you. Thank you for the organizing committee for inviting me here for the 3rd time, I believe. This is a very nice meeting about endoscopic spine surgery. And allow me to introduce myself. My name is Harman from Indonesia. So for this topic, I want to share to all of you my technique and experience about removing or extraction the flaphum ligament using en bloc resection or in toto resection, both using uniportal and biportal technique. So as you all know, endoscopic surgery gives fewer complications and neurologic injuries compared to open surgery, but I must highlight this only allow for the experienced hand. So when we are in the beginning of our career of endoscopic surgery, of course, we will encounter a lot of complication, but after you have steady and stable operation time, and now it will give you a fewer complication and neurological injuries compared to the open surgery. One of the great understanding of the microanatomy of the lumbar spine is must warranted. And one of them is the great understanding of the flaphum ligament itself. And the flaphum ligament can act as two kind of benefits. One, it gives us the anatomical landmark where we should go, where we should release and decompress. And another one is to give the nerve, the dural sac, its protection. So whenever you still have the flaphum ligament, you don't have to worry about the dural puncture or neurological injuries. And one of the common complication about endoscopic spine surgery is the dural tear. And me personally, I always puncture the dura when when using the kerosene punch. So I never puncture the dura using the burr or other tools. I always puncture the dura using the kerosene punch. So I think the lesser we use the kerosene punch, the fewer complication about the dural tear will become. And about the extraction of the flaphum ligament itself, we can do many techniques, but it used to be piecemeal. So we take a small piece of the flaphum ligament piece by piece. And another thing is en bloc resection. And to avoid using the kerosene punch too much, I suggest to all of you to start doing the en bloc resection of the flaphum ligament. So as you all know, the flaphum anatomy, it attached to every corner of the interlaminar space. On the cranial attachment, it attached on the anterior part of the upper lamina, while on the lateral corner, it attached to the facet joint itself, and it has an extension of the foraminal extension of the flaphum ligament. And for the lower part of the flaphum ligament, it attached both, one in the posterior part of the lower lamina and anterior part of the lower lamina. So it's kind of clipping the upper part of the lower lamina. So you have to know quite well about the flaphum ligament attachment to achieve the good en bloc resection. So we often see severe stenosis like this. I give you a sample of my video afterwards of L45 stenosis, and I approach with the left side approach. So this is the view using uniportal and one using biportal. So the first step is to release the cranial attachment of the flaphum ligament. This is the most easy part in releasing the flaphum ligament as an en bloc. You just simply burr the lamina. You can use the cutting burr if you're experienced, but for you that are beginning your endoscopic career, I suggest you to use the diamond burr to reduce the incidence of the complication. So basically, if you want to use the diamond burr, you should use on the side of the burr so you can get a good cutting of the bone. So basically, you just cut the lamina until you see attachment on the proximal part of the flaphum ligament. If you see here, it is almost released, but be careful not to push too much using a biportal or uniportal, or unless you can go directly into dura as I show you here. If you push it too much, you can just suddenly feel a loss of resistance, and it will give you a not good complication like this. But fortunately, I stop it just in time not to puncture the dura. But so be careful on releasing using the burr, not give too much push towards the anterior part of the fluffum ligament. So until you see the opening side, the insertion like this, is enough. So just leave it, and later on we can release it using curette or fluorescence. Okay, the second step is widening the lateral margin itself. So you may take a part of the medial facets, just enough to see the lateral recess. Okay, so this part is not that hard. You just simply do a bony work alongside the lateral margin of the fluffum ligament. And this part is viewing with the uniportal, and this part is biportal. So I do both uniportal and biportal technique because my experience, I do uniportal technique first, and then lately I start to study about biportal technique. So nowadays I still do both biportal and uniportal technique. So this part is simply just cutting the lateral edge, medial part of the facet. And next steps, this is the most difficult part, the release of the caudal attachment of the fluffum ligament. As you all know, the caudal attachment of the fluffum ligament have anterior attachment from the upper part of the lower lamina, and also the posterior attachment, and also the anterior attachment of the upper part of the lower lamina. So I find to release the superficial attachment of the lower fluffum, it is easy to do with the biportal. You can simply ablate using the ablator, cutting ablator, the fluffum ligament until you find the upper part of the lamina, lower lamina. While when you do with the uniportal, it's quite difficult because the radio frequency is not that good compared to the ablator with the biportal technique. So sometimes you can feel with the RF probe, and if you feel the bone, the upper part of the lower lamina, you can just simply cut it with the burr. But be careful, don't push it too much unless you will go inside the spinal canal. So you see here, the biportal is so easy to release the superficial attachment, while on the uniportal, we have to struggle a little bit to release the superficial attachment of the lower fluffum ligament. And you stop until you see some kind of thin layer, white thin layer here, just anterior to the fluffum ligament. Yeah, if you can see here, there is a very thin layer on the anterior part of the fluffum ligament, and that's the sign that your cutting burr is enough. And afterwards, you can release the attachment using some surgeons use curettes, but I like using the tip of the keratin acting like as a curette. So I don't use too much instrument when I do my endoscopic technique. And you go from the lower part of the attachment, go around to the lateral recess. So you release the lateral recess also after you do the lower part attachment. So as you can see here, I'm doing the lateral release attachment of the fluffum ligament. As you can see, I don't bite my keratin. I just squeeze and I pull the attachment of the fluffum ligament. So I don't cut the fluffum ligament itself. Yeah, until you see the complete detachment of the lateral part of the fluffum ligament. See, I just squeeze and I just pull. I don't cut the fluffum ligament. Okay, after you release the lower part and the lateral part, now you begin to release the contralateral part. The contralateral part is quite tricky because first of all, you have to cut the base of spinous process, and afterwards you can go from superior, from cranial to caudal, or you can do vice versa from caudal to cranial, depends on which is more suitable for you. So try to release as lateral as possible until you can see the traversing nerve root is free. So this is quite tricky. You can use the straight crescent punch, or you can use the curved crescent punch. But the most important thing that is you have to make a burr sufficient burr of the base of the spinous process, so your instrument can go to the contralateral side. As you can see here, you can see the lateral recess corner is already detached here. So after that, you just simply pull out. Oh, sorry, yeah. This flavum is already taken now. So after that, you can simply just pull the fluffum ligament as a whole. So if you see on the uniportal side, this fluffum is already released on every corner. So you just need to pull the fluffum ligament with the forceps. Okay, and it will look like this on the clinical, on the actual. So this is when we pull the fluffum ligament with the forceps. This is the left side with using the uniportal, and the right side is using the biportal. So sometimes the fluffum ligament is too big, so on your working channel, you might have to make a little bit incision more to take out the fluffum ligament. Okay, and this is the pre and post. You see the complete release of the fluffum ligament. So after I do this kind of technique, I never had the dural tear complication. So, and for me, the surgery is much faster. So the average time for me to do a single level uniportal stenosis cases is 34 minutes and 27 seconds. And with the biportal is faster, 29 minutes and 40 seconds. So in conclusion, en bloc resection of fluffum ligament gives safer approach and fewer complications. So for you guys who's still doing a piecemeal technique to taking out the fluffum ligament, I suggest you to try to do the en bloc resection of the fluffum ligament. And the biportal endoscopic technique gives more advantage compared to the uniportal endoscopic technique in fluffum resection using en bloc technique. So thank you. Go back to Dr. Shafruddin.
Thank you, Dr. Harmantia. Such a wonderful presentation. Thank you for sharing tips and tricks how to extract the fluffum ligament beautifully as a butterfly. So we move to another speaker. We move to Japan. Dr. Zenya Ito from Nagoya, Aichi Tokyo Spine Hospital. Please welcome Dr. Zenya Ito.
Yep. Just a moment.
Yeah. Okay. Please.
Could you hear me? And could
yeah,
you share the...
We can hear you loud and clear, and as well as your presentation. Please welcome. The time is yours.
Okay. Could you see that?
Yes, yes.
Okay, okay.
Perfect, perfect.
Okay, okay. Good evening, everyone. My name is Zenya Ito from Japan. So I'm very honored to be invited to such a great conference. So I focus on MIS surgery, UV, MAL, PED, and MED. So I research UV versus another operation. Today's topic is number 1, UVE versus MAL, and number 2, UV versus FEL. The first, I report the clinical comparison of the UVL versus MEL. Posterior spinal decompression surgery evolved from open laminectomy to the microscope, followed by microendoscopic decompression. Recently, a less invasive method, percutaneous endoscopic laminectomy, was developed. We started this clinical study in 2013, but in recent, there is next stage. The UVEL is a technique as in arthroscopic knee surgery that involves making two skin incisions, one for inserting an endoscopic and the other one for inserting a small steel instrument, performing bone drilling, and then extracting the yellow ligament, for example, Kelleson longe. The purpose is to compare clinical result of MEL with those of UVL in patients with single-level lumbospinal canal stenosis. Material and method is the subjects of this study were 181 cases, 139 cases MEL versus 42 cases UVL. All patients has spinal canal stenosis resistant for conservative treatment for 3 months. The exam items are BUS, back pain, leg pain, ODI, EQ5D, and operation time. And the bone resection area in 3D CT, the facet preservation rate in CT actual image. This is the baseline data. The baseline data in both groups is all not significant. A skin incision of about 1.6 millimeters is made at the target intervertebral site, and the tubular retractors is disposed at the intervertebral site. The lamina is exposed so as to drill the lamina with a 4.5 diamond burr. Upon identification of yellow ligaments, for example, a Kelleson punch is used to completely eliminate the yellow ligament on the right side to left side. Approximately 7 millimeters of skin incision for camera incision and 1 centimeter for inserting a still small instrument is located at the center of the higher level spinous process of the target intervertebral site. The incision will be separated by approximately 3 centimeters. The next, to expose the target intervertebral site, the soft tissue is endoscopically cauterized for 42 radiofrequency ablation to expose the lamina at the target intervertebral site. Subsequently, the lamina is drilled using a 4.0 millimeters diamond bar. Once the yellow ligaments is exposed, the yellow ligaments on the same side is removed. For example, a Kelleson punch. And on our side, we sometimes use the gouge like this. The decompression is almost complete. And drain is stayed. Result. BUS, low back pain, and leg pain, ODI, and EQ5D is not significant at 8 months. And operation time is also not significant. However, bone resection area and facet preservation rate of UVL are better than MEL. Although no significant difference was indicated due to the insufficient number of complications. MEL results in greater numbers of complications. Discussion. Moreover, the number of reports of UVL have been increased in recent years. Hale reported that higher facet preservation rate of UVL compared to those of uniportal endoscopy and microscopy. As for the bone resection area and the facet preservation, MEL has a small range of instrument movements as the maneuver of the surgical instrument is confined within a 16 millimeters tubular retractor and limited tilting. That requires some degrees of cutting of the lamina and the facet in order to remove the yellow ligament on the advancing side. In contrast, UVL, not using a tubular retractor, has a highly flexibility in maneuver of instruments, and a Carrison tool with a hook tip can easily be inserted, allowing for removal of the yellow ligament without significantly cutting the lamina and facet. In short, we can insert instrument under lamina. It is thought that this contributes to a smaller bone dissection area than the higher rate of facet preservation. Conclusion, the UVL is better MEL than MEL for small bone resection and procedure few complication. Next study. I reported the clinical comparison of UVL versus FEL. To compare the clinical result of FEL with those of UVL in patients with single-level lumbar spinal canalosis. Material method is the subject of this study were 128 cases, 80 cases FEL versus 48 cases UVL. All patients has spinal canal stenosis resistance for conservative treatment for 3 months. The exam items are BAS, ODI, EQ5D, operation time. And also the bone resection area in 3D CT, the facet preservation rates in CT actual image. And especially focus on L45 operation, we investigate Marx fetus atrophy at post-operative 3 months. However, we should exclude general muscle atrophy disease. So we investigate not operation area, L23, Marx fetus atrophy as control. The baseline data is all not significant. We choose bilateral decompression method with unilateral approach. Firstly, the laminectomy is started with detaching the yellow ligament from the upper margin of the L5 lamina because this area, the yellow ligament is not stuck strongly to the lamina's inner wall, so it is easily detached. Next, we must resect the ipsilateral superficial layer of the yellow ligament using a punch, and then detach the deeper layer from the upper and lower lamina using a drill. Then we detach the yellow ligaments from the opposite lamina and leave the medial facet, which will cause the lateral recess stenosis to decompress. Finally, after removing the ipsilateral medial facet, we should notice the root to be free at both sides. Result. BAS, ODI, and EQ5D is not significant at each month. and bone resection area and facet preservation rate is also not significant. However, operation time is better than FEL. And L23 and L45 multifidus LA atrophy is not significant at 8 months. Discussion. Some also reported MIS advantage about muscle complication, blood loss, and so on against open surgery. However, very few reports exist MIS surgery versus MIS surgery. So we investigated. Limitation is small number, short time follow-up, and so on. So we investigate more and more. Conclusion, the UBEL sufficiently show good result as FEL. Finally, we consider the UVEL is best decompression surgery in MIS as FEL now. Thank you for your attention. Thank you very much.
Thank you, Dr. Zenya Ito. Thank you for wonderful presentation. So we have a time, we ahead of schedule about 5 minutes. So I would like to bring up some, if there is a question and clearing to be made up by all attendees, please speak up, please. We have still, I would like to bring 1 or 2 questions. If there is any question, please, welcome. So, since there is no question, so I would like to close this session. I would like to give it back to Professor Kalali. Professor Kalali, please take your time.
Thanks, Dr. Siafruddin, to be host of this part of Congress. And thanks to all speakers. So now it's time to Dr. Hayati Aigoun from Medicabil Attention Hospital. The topic of this topic will be the role of UBE endoscopy surgery. So it's your turn, Dr. Hayati.
Oh, sorry, you mean. Okay, so you mean as or the number or in Japanese situation you asked?
Hello, Dr. Zenya Ito, and we move to the next speaker from the Turkey. Thank you very much.
Thank you very much.
And also thank you very much for the Dr. Hussein host and their Indonesia team.
Hello, do you hear me?
Yes.
Okay, thank you very much. Dear Chairman, first of all, I want to thank the organizing committee for their kind invitation. I'm very happy to be in this valuable meeting. And I will present you the role of biportal endoscopic decompression in spine surgery. Actually, I'm very happy to see before the speaks from my master, Dr. Son, and the others. So my presentation will be a summary for all before the presentations, because I saw very important presentations to compare the UBE with the other techniques is very important. And my presentation plan will be like this, as you see in this slide. And you know, spine surgical techniques are classified as open, MIS, and the endoscopic techniques. Endoscopic techniques also can classify as biportal and the if you know the endoscopic surgery as biportal or uniportal. And you know the endoscopic surgery is growing day by day. The spectrum of indications for endoscopy is widening. And the microsurgery is losing its role as gold standard technique. If we go more detail, endoscopic techniques are classified according to the portals. There are two main techniques, as uniportal and the biportal. If they classified according to the application medium, also we have again two main group, the air medium and the fluid medium. But if they classified by AO-Spine consensus nomenclature paper, there are two main groups, full endoscopic and endoscopic assisted techniques. The UBE technique is the last generation endoscopic technique, and it's kind of hybrid technique. So the technique has a special role in spine surgery. It means that the UBE is an endoscopic method. Also, it can classify it as full endoscopic technique because it's carrying the only full endoscopic surgery properties. For example,
hello, Dr. Hayati. We cannot see your presentation to play.
I shared actually, but
yeah, can you share your screen? Not share your presentation. Share your whole screen.
Interesting.
We can cancel it and share your screen again.
Okay.
Cancel the sharing and reshare.
Yes, I canceled. I don't know.
Yeah.
I'm sharing again.
Yeah. Yes. The first choice. The left on the right. The left on the top.
Right.
Left on the top.
Left on the top.
The first one. Share your screen.
Yes, I doing. I couldn't see my desktop to share. I couldn't see my desktop to share. I couldn't see my files.
At the bottom of your computer.
Yeah, I know. I trying to share and
yeah.
like this.
Yes.
Okay, then.
Your screen. Yeah. Yes, you can find your presentation.
I'm so sorry.
It's okay.
So I have to start from begin, right?
Yes. Yes,
okay,
please.
Thank you. Thank you. I'm sorry for the problem. I'm starting again. Dear colleague, My presentation plan will be like this, as you've seen in this slide. And you know, the spine surgical techniques are classified as open and MIS and the endoscopic techniques. Endoscopic techniques can also classified as uniportal and biportal. As you know, endoscopic surgery is growing day by day, and the spectrum of indication for the endoscopy is widening, and the microsurgery is losing its role as gold standard. If we go more detail, endoscopic techniques are classified according to the portals. There are two main techniques as uniportal and biportal. If they classified according to the application medium, also we have again two main groups, air medium and the fluid medium. But if they classified by Eospine consensus paper, there are two main groups, full endoscopic and endoscopy assisted techniques. UBE technique is the last generation endoscopic technique, and it's a kind of hybrid technique. So the technique has a special role in the spine surgery. It means that the UBE is an endoscopic method. Also, it can classified as full endoscopic technique because it is carrying all of the full endoscopic surgical properties. For example, the surgical interventions completely performing under the endoscopic visualization. Additionally, UBE technique is performing with the microsurgical principles. So, if we define the UBE technique, we can say that UBE is a surgical technique which has been performing under endovisualization for percutaneous, minimal invasive spine and spine-related structure surgery. This technique has many differences from others. It has widened visualization, which has most beneficial failure of view capacity. It is a very crucial point, the failure of view capacity. Also, it has high orientation capacity by help of separated portals. Despite of the fact that some canals or retractors uses for facilitating of the tool passing in working portal, but it is a real percutaneous technique. The technique is applicating in fluid medium. Hydrostatic pressure can be used very effectively by controlling of the fluid flow out. Additionally, it has flexible size working portal, which can be widened by using the retractors for using different tools. So the technique has big advantage in terms of unlimited tool usage. And in this table, we've seen the UBE advantage. Almost all the surgeries UBE superior or equal results with others. If we compare the endoscopic technique, UBE has many advantages besides minimal disadvantages. In all circumstances, UBE has very useful failure of view capacity, strong tools and big radiofrequency electrodes with different shape and size using is possible. The surgery can be done with conventional surgical tools like microsurgery. Another big advantage of this technique, assistance can be joined actively for retracting of the neurological or muscular structures. So you can use your assistant hand as an additional hand in this surgery. So but in other techniques, you know, you cannot use the assistant hand actively in this surgery, in the monoportal or uniportal surgeries. In this surgery, uniportal technique has more useful because of preservation of the fluid. In UBE technique, if surgeon can do fleum sparing technique instead of flavectomy, this disadvantage can be reduced. Separated portal usage is providing the unlimited tool usage and unlimited access to the target points. If you compare this technique with the microsurgery, UBE also has many advantages, as you've seen in this slide. First of all, UBE is a real percutaneous surgery, so the muscles and ligaments can be protected from devastating effect of the surgery or the muscle retractions or eccartations. And the fluid medium endoscopies, especially UBE, the dura is deflated by hydrostatic pressure. So endoscopy is providing more and clear working space when compared to microsurgery. In another word, if you try to the microsurgery for adjacent segment, the surgery became open surgeries. But the endoscopic surgery can be done for multi-level surgeries. Let's see all this in some videos. This is the disc surgery. In this video, we have seen that how the technique is effective for preserving the surround and innocent tissues. We're doing separating of the fleum from the lamina after 1 or 2 or 3 millimeter laminar drilling. No need to the flavectomy to do this is the 2 millimeter dissector. Now you see the disc fragment. Now we're doing the fragmentectomy. The crucial point is the pre-operative planning. If you do proper planning, pre-operative planning, you don't need to touch the peridural or epidural and the fleum interface. It's very crucial to preventing of the fibrosis and development. Just we're doing fragmentectomy. The differences with the other techniques, the clear visualization and unlimited tool usage without bleeding and controlling of the hydrostatic pressure. Just removing the fragments. No need to touch the other tissues, even small vessels. Yes, it's finished. And the other case, this is congenital stenosis with the disc herniation. The case was very young. Now, in this video, you will see the circular spine endoscopy. Circular spine endoscopy. With UBE, we can do circular surgery. It means that I will show you another video. We also can do the foraminal decompression, lateral recess or subarticular decompressions, and the disc decompressions or discectomies or fragmentectomies. I want to make a little faster. After decompression, now we can manage to the disc. Another big advantage of the UBE, you can use the different shape or size radiofrequency electrodes like this.